And I hope everybody can see. You want me to enlarge?
Yeah, it looks good.
Okay. All right. So this is a patient with multiple, of course, cardiac history here from coronary artery disease, CABG, with good thing, heart failure with preserved ejection fraction, which is, and then persistent AFib, had mitral valve replacement, had six sinus syndrome, had PACER, along with other comorbidities here from OSA, hypertension, hyperlipidemia, hypothyroidism. It's almost like multiple systemic involvement here. So fairly independent, but of course, decreased mobility. And has a lot of assistive devices here, from cane to walker to electric scooter. And then chronic back pain. So I think the reason why Dr. Kirkpatrick wants our input here is because of this multiple ER visits and hospitalizations, plus polypharmacy. And I'm just going to answer the call here. I'm so sorry. So Lara just called, so I'm just sending her the Zoom link. She can't find her Zoom link. So sorry, time out. And Denise, if you don't mind screen sharing the rest of the patient X information, that would be great.
That's fine.
Thank you.
Your call cannot be completed as dialed. Please consult your directory and call again, or ask your operator for assistance. This is a recording. Your call has been forwarded to an automatic voice message.
I think Lara is here. Hey, Lara, I'm glad you're here.
I am so sorry I'm late.
We were able to go through until first page, the hospitalization. 2021
Is that too
10-year
small?
visit. Yeah, if we can just do like one page instead of multiple pages.
Okay.
Thank you. And then you can take it away. I'm just presenting our chief res, Lara, to the group. Thank you for sharing your patient. So we were able to go over the first half, and then you can continue with the rest from the
Okay.
hospitalizations down onwards.
Okay. So had several hospitalizations, and actually there are even more than it says on the sheet because she was hospitalized again fairly recently. Sometimes she comes to our service. Lately, she's been going to cardiology rather than to our service. She has, cardiology seems to think she's been optimized as far as her AFib goes and treatment for that. Most of her ER visits and hospitalizations start with either chest pain, shortness of breath, or palpitations. That's why she goes to the ER. She ends up sometimes getting admitted. She does have a habit of leaving AMA from hospital. So sometimes it's difficult to optimize her. She's been through several cardiac procedures, including cardioversion, Mays procedure. But I just can't seem to get her in a place where everything is optimized and the specialists are all just looking at one little thing. And that's why I was hoping a multidisciplinary group, especially one who can look at things like her polypharmacy, could help her. I did ask her at one point, what is it you're getting in the ER that I'm not giving, that I'm not able to do for you? Her answer was pain meds at that time. She does have chronic pain. She gets injections, but in her back, but she's not on specific pain meds other than she does have gabapentin, but when she goes to the ER, they give her morphine and Dilaudid. She was complaining a lot about chest pain. She basically kept being pushed off as, pain seeker. Turned out she had, when they finally did a cath, she passed her stress test, everything else. They finally did a cath. She did have 100% blockage in one of her vessels, 90% in another. I mean, she did have a reason to have chest pain that everybody had sort of been saying, this is just seeking behavior. So like I said, I struggle, but now, she's had a recent cardiac cath. She's had the procedures for her persistent AFib. I'm just at a loss as to what more I can do without, sort of stepping on toes of specialists who are saying, well, for this thing, she needs this. But they're not looking at the other issues that she may have.
So hi. Oh, I'm sorry. Go ahead. I didn't mean to interrupt you.
No, go ahead.
So my name's Sue Fosnight. I'm a pharmacist, and I just wonder about trying to optimize her pain medications. I mean, right now she's getting those injections, but it doesn't sound like that's enough. So probably, I hate to add more meds, but giving her some, our standard really would be some scheduled acetaminophen to try to help with that. I don't know if she's tried that before. The other thought with her back pain would be to switch her sertraline over to duloxetine. So to try to get the pain relieving effect from the duloxetine rather than along with the depression and anxiety effect. So that would be one thing I would think of.
I believe we tried duloxetine in the past and she didn't tolerate it well.
Okay. The other, I don't know if you've also tried venlafaxine, so I'm just trying to get her on an SNRI. That would be, some people don't tolerate duloxetine, but they will the venlafaxine. Although with her anxiety, she might get a little bit more anxious the first few days that she's, really the first couple weeks that she takes that till she gets used to it. So that was just one idea I had about her pain. I don't know if her anxiety plays into her pain as well. Like most people have anxiety that kind of plays into the pain, and whether increasing her buspirone dose may help a little bit if she is anxious, despite what she's currently on.
Okay, thank you. She is also, I have issues with her being intermittently compliant with medications. Her diuretics was a big issue for a long time. She kept wanting to do Lasix. Bumex worked beautifully for her, but she didn't like how it made her feel. So she kept going back to Lasix, but she was pretty resistant to it at that point. I finally cardiology switched her. I believe she's on the torsemide now.
Yes, yeah, she is on. Is that going well with her on torsemide?
It is. I think she still sometimes doesn't take it because obviously it makes her need to urinate a lot, and she doesn't like that if she's, trying to do things. So like I said, sometimes she can be intermittently compliant. But I'm just trying to get into her file. Sorry, just to double check what we used to have her on. But yes, your suggestions, I appreciate that. Thank you.
I'm gonna look at her gabapentin dose too, because that might be something that can be optimized.
Mm-hmm.
So she's on 900 milligrams a day in divided doses. So, just looking at her creatinine clearance and see if she could actually be increased with that. That's kind of the middle of the road dosing for her. So if her creatinine clearance is over, I believe 60, she would be able to go up higher on that dose. And I don't know that she would have a creatinine clearance that high with all of her issues, but.
Yeah, I'm looking to see what her last one was.
So that idea that she's going to the ER with opioids, certainly something that's fairly common. And my pharmacy student did mention that she does have some edema, and yes, that is true that we would have to watch if we increase the gabapentin to make sure her edema does not get worse.
And it looks like her GFR on our last labs We're okay. I'll have to double check. I'm in a half version of all scripts right now, so.
Yeah, I think optimizing, trying to get her pain under control so she doesn't go to the ER for pain. It's like a common thing that I see these days.
Yeah, and since the cath, she's gone, it seems to have actually decreased the number of visits specifically for pain. Now it's often shortness of breath or the palpitations, because that AFib is just so persistent. But yeah, she as she says it, she likes her Dilaudid.
Yeah, is she using, and sorry, so her pain is primarily in her back?
What she goes to pain management for is in her back, and then she complains of chest pain.
Oh, she goes to pain management. Okay.
Okay, so
Yeah.
back pain and then the chest pain, which is thought to be at least a contribution of cardiac, though that's being addressed from that standpoint, but might be some musculoskeletal stuff too.
Right.
And then with the gabapentin, does she have specific neuropathy?
She does. Sorry, I'm trying to.
Maybe with the back pain.
Yeah, I think it was because they didn't want to give her opioids.
So it does have some evidence about using it for just somatic pain as well.
Mhm.
So just trying to tease out like what type of pain that she's having, right? So, you know, I'm in pain and sometimes it's really hard. I'm Dr. Gendros, by the way, I'm the geriatrician on the team.
Oh,
So sometimes it's really hard to get people to like actually like describe what their pain is, where it is, right? If you've gone through that process, you're like, well, is it burning, aching, stabbing, that whole thing? But like really trying to pinpoint what is her like main focus for her pain, and then what are all the other contributing things or types of things. So it might be like it is, you know, that grinding kind of aching, like just in her low back, and that's the thing that makes her not want to move, makes her not want to get up and take her medicines, makes her not want to do that, right? Like versus it's, yeah, that's there, but what's really bothering me is the burning in my feet. You know, that's the part that I can't get rid of. That's the part that I focus on. So trying to tease out that a little bit. And then using that to kind of really drive what some additional treatment recommendations might be. You know, is that a really, again, there's overlapping indications and evidence for a lot of the medicines, but I think that can help, and it can also let her really, I think, let her know that you're teasing all these things apart because you care about this, and this is what's, you know, her main complaint is, and just kind of helps to maybe build some of that rapport and safety and trust that it sounds like she also lacks at times. So that would just be one of my thoughts, and then kind of using that, yeah, as Sue was saying, to adjust those medications. And then has she tried anything topical?
I've suggested topicals. So when I try and parse out what is the pain and what pain is sending her to the ER, it's always chest pain. So she will mention the back pain, but it's always the chest pain that sends her to ER. So I've had a difficult time trying to get her to really tell me what exactly is, you know, as you said, try to parse out where is it, what kind is it, what does it feel like. So I will try again with that. She does complain a lot of restless legs and discomfort with that. That's not really pain, but it causes her a lot of discomfort. She was not able to tolerate some other medications specifically for that. And usually when she's not tolerating a medication, it's also hard to pin down. I just don't like how it makes me feel. I feel weird. Like I often can't get a really good reason why that medication isn't helpful. So, okay, so I've got some work to do here with trying to get her
Yeah.
again to explain. if
The
at all.
other thing that comes to my mind, and I don't know whether this is appropriate or not, but I wonder if she has a diagnosis of pulmonary edema and whether that pulmonary edema is actually, contributing. She's not on one of the medications that are available. They're all kind of new. They're all expensive. They require specialty pharmacies. They're kind of complicated. But you wonder if that medication, one of those medications, they're called endothelial receptor antagonists, like either probably ambrisesen, AMBRISENTEN, would be, and then also our one that's been out longer, the tadalafil, whether those are meds that she qualifies for, whether that might help her be more comfortable. Would be one of the things that I would think about also. Now, she's got cardiac following her, and it really kind of depends. This is a question that just came up for me not too long ago, is who prescribes these medications when someone needs it? Some cardiologists will do it, but in my experience, not very many. It's usually pulmonary that's doing that.
Yeah,
And I don't
she
know.
does cardiology and heart failure clinic and pulmonology.
She does have a
All on
pulmonologist.
board. Yeah.
So you might just ask, because those are newer meds that that maybe not all practices are using because they're kind of complicated to get. But, if you contact a specialty pharmacy, usually a specialty pharmacy can help to do that. So just, does she qualify for one of those?
Okay, thank you.
And I have some other comments that some students have brought up that I wanted to just go through. So she's also in trazodone, and I think the trazodone is being used along with the sertraline in a dose that's probably for sleep. Is that primarily what it's being
Yes.
used for?
Yeah.
So she's not having any signs of serotonin syndrome for the student who spoke about that, so I wouldn't be real concerned. And I know we didn't have diabetes on the list, but I assume that she's also has diabetes. Is that correct?
Yes, she's on just metformin for that.
Yeah, so, okay. And I think those were all of what the students had asked. Oh, just that she also has some RLS, but the gabapentin is probably helping to cover that.
Yeah.
And then maybe, I don't know how bad her pulmonary function is, but has she gone to cardiac rehab and pulmonary rehab, or either one of?
We've tried that, yes.
Yeah, that's what I figured.
Yeah.
And I know she has cardiology on board, but I see she's had a mitral valves, and they probably have been down this road and decided the benefit outweighs the risk. But I know apixaban's not really been approved for anything that's related to AFib that's related to a valve.
Mm-hmm.
So that would be just something to make sure that conversation has already been taken place. I don't have too much else for you as far as meds go. I don't know. Is her QTC greater than 500?
It has been in the past. I don't have her most recent.
Okay, so cardiology is following. They have an unusual regimen, the sotalol and the metoprolol, but I imagine that's because they can't increase the sotalol.
Yeah.
And she does have something, I didn't see it listed on here, but again, she does have something to use, like a nitroglycerin, if she has acute angina pain that she uses.
Yeah.
So the other thought would be to sit down with her and talk to her about, what does she do when this pain occurs? You probably have already done that. It sounds like you've already done that, but maybe have a written plan for her, okay, the first thing you're going to do is to make sure you took your morning meds or take a nitroglycerin if the pain is severe, and kind of give her some ideas about when she should go to ER and when she should call you, which you probably have already done also.
I haven't done a written plan, so that's a good idea.
I think the written plan, and honestly, to be honest with you, just from my experience with older patients, like a handwritten or a typed, not part of something that you hand them as an after visit summary, actually gets more use from what I have seen in my older population.
Okay.
Because sometimes when it's at the end of that 8-page thing we hand them, they just don't. They can't find the right spot.
Right.
It's
Yes.
overwhelming to them.
Yeah, and I think she would be open to and benefit from a separate, just here's the plan. So
There were
yeah.
some.
That dovetails well into, right, I mean, she has a lot going on, so some disease self-management skill building would be good too. And I know the Direction Home has resources and services available, even if they don't qualify for Passport or all of those things.
Okay.
So Lori is nodding her head there. And then I think Janet Raber also had some great points about utilizing the rest of the office-based team for increasing those touch points with her. Again, building that rapport, building that you can call us, you can trust us, right? You don't have to, in every episode of chest pain, go to the emergency room, like those types of things. Janet, I don't know if you wanted to just comments are there, but
yeah, if she feels like we had a special care team at Suma's family practice, and these were frequent flyers and people with I mean, she would be a perfect example. And what we found is that they had a special care team appointment, and as frequently as you deem necessary. And sometimes it was once a week until they got that trust built up. And we blasted them with everyone in the office: behavioral health, pharmacy, social worker, her personal nurse, and then her resident and the attending that was supervising attending. And she could identify her team members, and she also had easy access to the phone. So when she called in, she just identified herself as a special care team patient, and she got through immediately to a nurse instead of going through the telephone tree. She may have that. It allays the anxiety, and then, the anxiety and the depression and all that other stuff. And once she knew that she was going to be taken care of at the office, she quit using the emergency room. So care coordination is really, really important with this particular patient. And you can put your staff on her as a project and say, okay, we're really going to focus on her as what we can do overall. How does she call an ambulance every time she has chest pain? Okay.
Usually, sometimes her fiance will drive her there. Otherwise, she calls EMS. And before COVID, she would come to the clinic regularly. I did see her regularly. COVID happened and everything kind of fell off the rails because obviously she's a high risk patient. But yeah, I hadn't thought about this sort of special coordination type situation. So that's something I'll talk to our case manager and social work about.
We had one patient that was admitted 25 times in a year, and she had over 100 emergency room visits. And after the 6 months on a care coordination team, she actually decreased her admissions. She went 100 days without an admission. So yeah, so it was really a dramatic change, and we did. And the other, we also on our team, we had spiritual care too. So it was almost like a hospice care team.
Right.
But we applied the hospice principles to the special care team care coordination.
Okay. All right. And I have tried to get palliative on board for her too, just to try and get, sort of some of that aspect with spiritual care and some extra support, but she's not always been very responsive.
I've had similar experiences with a team that we call it our high intensity clinic and similar types of decrease in readmissions. And even though she's not coming in person, I think those phone calls in between by your staff can help a lot to prevent, just kind of check in and reinforce what the plan is and make sure that she understands that. And then the other part is really, you have to be available. So if she calls, I mean, a lot of people have those trees now that it take a while to get somebody to actually be able to talk to her. So if you had the ability to have her call into somebody in particular, that helps to prevent that as well. The other thing is, I am worried about her adherence, that you said that she, very common not to be adherent to diuretics, but getting a pharmacist to sit down with her. I don't know if you have a pharmacist in your office or if there's a pharmacist that is available to you. If not, calling her retail or her community pharmacist, I'm sure they would be willing to do that as well, to sit down with her about why she's missing medications and try to come up with some ideas of how to deal with some of the side effects that she's having so she doesn't miss those medications. And again, she's being followed by cardiology, so I trust that they are doing it, but I would just also wonder if she needs maybe a higher dose of her MDR, maybe that she can't tolerate that higher dose. She's only on 30 milligrams, and you can go up quite a bit higher than that. So that might also help to decrease her chest pain. I don't know if maybe her blood pressure doesn't allow her to go up on that.
I'll talk to them.
Okay, so I have a couple of concerns here for this patient. I looked into the ubiquinone, the coenzyme Q10, that she's on 50 milligram capsule twice daily for 30 days. So I looked at the American College of Cardiology, and it says that they don't support the use of the CoQ10 in cardiovascular disease or heart failure. So I was just wondering why the patient will be on that one.
That I'm not, I'll have to ask about that one.
Most of the time people are taking coenzyme Q10 for the side effects of the atorvastatin, to allow them to take the atorvastatin. So there is a little bit of data, Daniel, on that, that coenzyme Q10 will decrease the muscle aches and pains that people may have with the atorvastatin. But that is a good point. That it's definitely would not be something that we would treat her heart failure with.
Okay. And yeah, I now that you say that about atorvastatin, I know she has had issues with the statins in the past, so that may be why, but I'll confirm.
Yeah,
that.
definitely something that I think really those muscle pains with statins are pretty rare. So just reinforcing how important it is for her to take the statin. She's somebody that should really be on a statin. Anything else, Daniel? You said you had another one?
Yeah, so I see that she's on omeprazole 40 milligram twice daily for 90 days. And usually, according to the BS criteria, there's a potential risk of fractures and bone loss. We usually don't want to limit it to 8 weeks. If it's more than 8 weeks use of the omeprazole, we have concerns. So I'll just worry about 90 days.
And I think that's a very good point. Also, the one thing with that tree, as we go through trying to de-prescribe, is first thing we look at is she is on apixaban and aspirin, so she's a very high risk for bleed. I'd be hesitant I definitely wouldn't take it off. I thought about maybe decreasing the dose, but I think with the dual, the anticoagulant and the antiplatelet, that I'd probably leave it alone.
She may also have Barrett's. I want to
Oh,
double check
okay.
that, in which case she needs the PPI.
Yeah, unfortunately, sometimes we have to use them.
And then the last one is definitely we want to see the physical therapist so he can do a little bit of movement for exercise and
Yes.
healthy. If he can see the nutritionist, basically to maintain an overall healthy weight with whatever is going on.
Okay.
Very important.
Yeah, that's a great idea. Thank you.
Yeah. I have talked to her about physical therapy. I don't think I have about a nutritionist. So for that, I'll definitely talk to her about that. And again, about therapy, we've talked several times about keeping mobile, keeping strong. When we were talking physio versus pulmonary rehab versus cardio rehab, but I'll try again on that.
Does she sleep okay?
No. She said with the trazodone, it's helpful. Usually when I talk to her about sleep difficulties, she mentions the restless legs is what tends to interrupt her sleep the most.
So if we were going to increase the gabapentin, I would give it at bedtime, the higher dose. So gabapentin has become the drug of choice. And with all the other meds on, I would probably try not to give her a dopamine agonist, but definitely we could increase that gabapentin. I did look up, as long as her creatinine clearance is greater than 50, she could go up to 1,800 milligrams per day.
Okay.
I wouldn't necessarily go up, very quickly on that, try to minimize that use as much as we can. But
Yeah.
I think, and my thought was that her melatonin, there is such a big difference in melatonin products. So if she is not doing the USP brand, I think there's a Walgreens brand that is USP, and then there's also Nature Made has a USP brand. But if she's not having a USP brand, she may not be getting much melatonin in there.
Okay, good to know. I did not know that.
Okay, go ahead.
Sorry. I just also want to bring up the fact that she's not compliant on the CPAP.
Oh, very good point, Melinda.
That has to be contributing to her sleep and her heart issues, and giving more sedatives for sleep. It concerns me with her not breathing at night. And then we're giving her something that's even more sedating. So do you know what the barriers are, or why she's not willing to use the CPAP?
She won't use it because she doesn't like the mask on her face. We've had several conversations. I've talked to her about the newer equipment. Whenever she's in hospital, she ends up on BiPAP at some point because of her respiratory failure. She'll take that off. She says straight up, I would rather die than wear a CPAP or a BiPAP. She said, I understand that is the risk. She knows that exacerbates all of her chronic conditions. And she said, I don't care. I will not wear it. So that's a battle. I continue to encourage her. But
yeah.
I know that I'll never win that one. I just keep trying because I know it's so important. And yeah, she's straight up said, I'd rather die.
So, and I'm sure you've already done that they have different masks she's probably already been tried on different ones. Okay. And the gabapentin is much less likely to cause problems. It does not decrease respirations like our opioids or the benzodiazepines do, and the melatonin also is much safer than using something that's going to decrease respiration rate.
I was more concerned about the trazodone.
Yeah, it also does not decrease respiration rate.
Okay, thank you.
So how is her thyroid function doing? How's her thyroid levels doing? Because it looks like she could have been on it for a little bit. So I was reading, and although it's not they didn't comment about the frequency of risk of heart failure and increased blood pressure. I would consider checking the thyroid levels to see if he can get off the Levoxel.
Okay, I know when she's in hospital, her TSH has been checked. I don't know that it's been checked recently when she's not in an acute illness, so I'll double check on that.
Okay, anybody have anything else, or? Hopefully some of this will help you. She sounds like a
Yes.
very difficult patient.
She isn't, but she tries to be cooperative, and she's open to some things. There are just others that she just straight up says no. So a lot of your suggestions I so appreciate. I definitely have some new ideas and things I can work with her.